Thank you. So, hello everyone, and welcome to this webinar for the Postgraduate Diploma in Practical Dermatology in module MET 605, which looks at environmental challenges in relation to the skin and practical dermatology. My name's Dr. Flora Kiss. If you haven't seen me yet on this program, I'm the course lead, and I'll be hosting this webinar today, which is based around some cases that I'd like to share with you, which are all related to environment and the skin in some sense. I know that many of our learners are working in different time zones, and all of our students are busy working professionals. So I know that many people are not able to join us. There's no one time that would fit everyone. And this might be because of work commitments, but also because of personal family commitments and so on. So we are recording this session, this webinar, and you can watch it back later on demand as well. This will be put up within the module MET 605. It will take a few days for the recording to be put up, especially because it's a Friday afternoon now here in the UK where we're hosting the session. But it will be available throughout the rest of the module, and you can go back to it later as well. So I'm going to just bring up my slideshow, so bear with me a moment, and then I'll share my screen with you. And for those of you who are present, if you have any questions, any comments throughout the session, please feel free to unmute yourself and ask your questions. And also, if you have anything you'd like to say in the chat, but you don't want to interrupt the session, then please pop them in the chat and I'll go and look at that chat after I finish with the cases and we can have a discussion. I did prepare for a bit of interactivity, but I don't want to put you two on the spot since it's only a couple of you who have managed to join the session live. So I'm not going to ask you directly, but if you want to have a discussion about any of the cases, then please let me know. Does that sound okay?
Yes.
Great. Okay.
Yes,
So
fine
I'm
by me
going.
too.
Sounds good?
Yes, yes, thank you.
Great. Okay, so I'll bring up my slides. Bear with me a moment. Can you all see my screen now?
Yes, I can.
Great. Okay, thank you very much. So we'll begin with this webinar, which has some cases I've collected that are structured around environment and the skin. So the first case I have is of a lady who's in her late 60s, and she presents to clinic with a very itchy rash that has been ongoing for months. And as you can see, it affects her face, but also what we don't have on this image is that it also affects the back of her hands and the upper chest. Now, on history, when we had a chat with this lady, it transpired that the rash was worse in springtime and summer months, but it was present all year round. And her most important complaint was the itching that really impacted her, and it also led to some sleep deprivation in her case. And when we had a closer look, we saw this erythematous papulosquamous rash with slight scaling. And when we had a closer look, there were some areas that were spared, which gave us some diagnostic clues with the history. And we then referred this patient to our specialist photodermatology clinic for monochromator light testing. And following this monochromator light testing and the clues in history, as well as the clinical examination, a diagnosis of chronic actinic dermatitis was made. So on the monochromator light testing, which was done on the patient's back using different wavelengths from within the UVB, the UVA spectrum, as well as from the visible light spectrum, the patient was found to be sensitive to both UVB and UVA different wavelengths. So there was an increased photosensitivity, and the location of the rash also affecting the face, the backs of the hands, and the upper chest is typical for chronic actinic dermatitis. And what we saw on examination, which you can't really see that much on the picture, was that in some areas there was sparing, which are not in a sun-sensitive location, so which are not sun exposed, for example, behind the ears or just underneath the chin where the sunlight doesn't reach the skin, those areas were spared. Now with chronic actinic dermatitis, the pathomechanism and the pathogenesis is not completely understood, but it's thought to be similar in a way to allergic contact dermatitis. So it's hypothesized that it involves a delayed type hypersensitivity reaction. The difference being that there's no exogenous antigen like in allergic contact dermatitis, but there is some cutaneous antigen, a molecule in the skin that is somehow altered by sunlight. And this is the antigen that then reacts. And together, so with sunlight, which is, sorry, that was just an update and antivirus software. So chronic actinic dermatitis is one of the idiopathic photodermatoses, and as I was saying, it's similar to allergic contact dermatitis in the sense of pathogenesis and pathomechanism, but it can also present with chronic allergic dermatitis. So these patients can be more prone to contact allergies, and therefore patch testing might be indicated in some of the patients with chronic allergic, chronic actinic dermatitis. The most common allergens are fragrances, but sunscreens may also cause reactions in these patients, or airborne contact allergens such as from different plants, for example, the daisy family. Now, chronic actinic dermatitis management is similar to atopic dermatitis and allergic contact dermatitis, so involving emollients, involving potent topical corticosteroids or topical calcineurin inhibitors such as tacrolimus or pimecrolimus for milder cases. So in this case, pimecrolimus might be too mild to use. But systemic agents are also used in many instances, for example, systemic corticosteroids or corticosteroid sparing agents. For example, in this lady's case, mycophenolate mofetil was used, but other agents such as azathioprine or cyclosporin may also be used, for example. Monochromatometer light testing, as I've mentioned, is a specialized test, which is only done in some special centers. So here in Cardiff, we do have a special photodermatology service with the monochromator light testing being available and a specialized photodermatology clinic as well for these patients. And this looks at the photosensitivity and the triggering wavelength that may be present. And in cases of chronic actinic dermatitis, it's very common to have sensitivity to UVA wavelengths. So that's the spectrum from around 320 to 400 nanometers. UVB photosensitivity is also commonly present. That's from about 280, 90 nanometers up to 320, up to the UVA range. And in some cases, in severe cases, patients might even be sensitive to visible light, which is from 400 nanometers upwards. So obviously photoprotection is really important in these patients, and photoprotection being combination measures. So not just the use of sunscreens. Sunscreens are a part of photoprotection, but also behavior modification with staying out of the sunlight as much as possible. For example, I've just seen another patient with chronic actinic dermatitis this week in my clinic, who is a regular follow-up patient in our clinics. And during the summertime, he only goes out for walks very early in the morning when it's still dark, or late in the evening when it's already dusk and afterwards. And also covering up with clothing is really important for these patients. Now, I see that something popped up in the chat, so let me just come here for a second, have a look if there's any questions. So thank you, Sophie, for your questions. Were there any systemic symptoms, and how do we differentiate from simple heat rash or pre-existing dermatitis? So thank you. These are relevant questions. This patient didn't have any systemic symptoms, and usually systemic symptoms are not part of chronic actinic dermatitis. The features, as I've said, are similar to those with atopic dermatitis, atopic eczema, as well as allergic contact dermatitis. So it's not always easy to differentiate between these, but the symptoms are very similar. Lichenification can also commonly be present. What can help with the physical examination, as I've said, is that there is usually some sparing in the sun-protected areas. So if you examine patients behind the ears, underneath the chin, or some other areas which are sun-protected, they're usually a bit spared. However, having said that, chronic actinic dermatitis might spread to even sun-protected areas of the body, especially if it grumbles on. That can happen. And as I've said, it may coexist with atopic dermatitis and allergic contact dermatitis as well. So these patients are more prone to developing other eczematous dermatitis symptoms. So sometimes it's not easy to differentiate. But the monochromator light testing will definitely be helpful, because that can help with showing reduced sensitivity to UVA and or UVB and possibly visible light. So if you do have the option to refer patients with suspected chronic actinic dermatitis, and these are usually older patients, it's more common in men. It may affect women as well, but it's more common in men and typically in older patients, it appears. So if you do have the option, then it is worthwhile, I would say, to refer them to specialized centers. And in the history, what can help is that it tends to be worse in spring and summertime and with sunlight. But again, once it's established, it can grumble on throughout the whole year. So I hope this helps with your questions, Sophie. And then we will move on to the next case. So this next case, you might be looking at it and wondering, thinking, this case, looks papulosquamous rash. It looks psoriasiform. And you're right. This is because this case is a case of psoriasis, but I wanted to highlight a case here specifically where you look, you can see that the sun-exposed areas are a bit more affected, although the patient does have some psoriasis papules and small plaques on the chest as well as on the back. You can see that the shoulders and the upper arms are affected more to an extent. And this is because this patient has photosensitive psoriasis. So as we know, psoriasis patients overall generally tend to respond well to sunlight. And psoriasis usually improves in summertime with sunshine. And most patients tell us that their psoriasis and rash will be better if they go on sunny holiday or just during the summertime. And we use phototherapy as one of the treatment modalities for psoriasis, and many patients respond well to narrowband UVB phototherapy, which is usually used as first line from phototherapy, or some patients might be going on to receive PUVA treatment. However, some psoriasis patients have their rash aggravated by sunlight, and they might be worsened. So it is worthwhile to consider asking the patients on history, psoriasis patients, if their rash is better or worse in the summer, if it improves with sunlight or if sunlight makes it worse, especially if we're considering a referral for phototherapy as a management option. Because in the literature, if you have a look, you'll find that there are some cases of psoriasis patients who are photosensitive, whose rash is aggravated by sunlight. Now, the percentage varies, so it will depend on the type of article you read, and especially of the patient's geographical location. So some papers put this at about 5%, whereas others put this at 10 or maybe even higher at 15%. The higher percentages coming more from northern countries, so for example, Scandinavia, where photosensitive psoriasis might be a bit higher. So it is just worthwhile to have a think and talk to your patients about if the rash is better, worse, and in summertime and summer months, and how they react to sunlight. So the next case here, you can see a man in his early 30s. And what you can see here is another psoriasis patient. Now, you can't see the psoriasis at the moment because it's in remission. However, this patient has received multiple courses of phototherapy already with some narrowband UVB, as well as some courses of PUVA photochemotherapy. So PUVA is where they receive psoralen as a photosensitizing agent, which is usually ingested as a capsule. But there are other types of PUVA therapy where the psoralen is not ingested but used topically. For example, in bath PUVA, the psoralen is added to bath water, or there can be PUVA gel or liquid, which is just used for hands and feet, for example. And then once the psoralen is either applied topically or ingested by the patient, then UVA phototherapy is used in combination. Now, this patient has received multiple courses of PUVA therapy and developed what's called PUVA lentigens. So lentigo is the singular form, and this is similar to what a solar lentigo would be. So usually tan brown, anywhere between light brown to a darker brown shade macule. And you can see that this patient has multiple, and that's why it's called PUVA lentigens. And it's a rare side effect which may occur with PUVA therapy, as well as, for example, PUVA itch, which is also another rare side effect. This patient didn't have PUVA itch, but has developed PUVA lentigens. And you can see one of them was monitored, then it was measured, it was also looked under a dermatoscope, but there were no alarming or sinister features found, and the patient was just followed up because, as we know, one of the side effects with phototherapy can be increased skin carcinogenesis. So especially with multiple courses of phototherapy, and more so with PUVA than with narrowband UVB treatment, the risk of skin cancers increases, and this patient has been followed up. Now, if you're more interested in the topic of phototherapy and skin cancer risk, then I can recommend that you might want to have a look at, there are several groups in the world who have published, who have followed up for many decades now, patients who have undergone multiple phototherapy sessions. And in particular, in the United States, there's a group led by Stern et al., who have followed up psoriasis patients for quite a few decades now, who've received many courses of phototherapy, including PUVA therapy. And they have published more articles on the topic as they follow up this quite a substantial cohort of psoriasis patients. So if you're further interested in phototherapy and skin carcinogenesis, then I can recommend that maybe you have a read of their publications. But there are also other groups from around the globe who have looked at this in detail. Okay, so now the next case is not a very difficult one. You might have seen quite a few patients with this condition, which is a photoaggravated rash. So it's one that's not caused by sunlight, but it's exacerbated, it's worsened by sunlight, and this is rosacea. And of course, with rosacea, what we can see is this erythematotelangiectatic rash, so telangiectasia and erythema, especially on the cheeks and nose. There's also papulopustules, which are very commonly appearing in rosacea. And this was a lady in her early 40s who has said that this rash is worse in spring and summertime. It affected her quality of life and her self-esteem because she felt that people were staring at it. And when she felt under stress, then she felt it was worse, and she complained of flushing, which is a typical symptom of rosacea. Upon further questioning, she has said that the rash was worse when she consumed hot beverages or alcoholic drinks. And this is also something that is possible with rosacea. So let me see, there was just something in the chat now. Sorry, I'll go back to rosacea, but for some reason, yeah, I couldn't bring up the chat. So write a link to the study, Stern et al. I'll try to look up the link and maybe put it up. I don't have a link to the study per se. I've read it, a while ago. So sorry, Sophie, I don't have a link at the moment. But if we have a few minutes after the session, I might be able to look it up. But it is Stern et al. And if you look them up with phototherapy and skin carcinogenesis, skin cancer risk, then you will find them. If we have a few minutes at the end, then I will have a look, okay? So going back to rosacea, management options include topical management, for example, topical ivermectin, which is very commonly used under the trade name Solantra cream in the UK, but there are also other topical agents, topical metronidazole, topical azelaic acid, which might be beneficial, or systemic low-dose tetracyclines. And with the tetracyclines, it's more the anti-inflammatory effect. So obviously they're antibiotics, they have antimicrobial effect, but it's also known that the tetracyclines have an anti-inflammatory effect as well. And it's especially why they're used in rosacea and in some other dermatology conditions. For example, hidradenitis suppurativa, we also use the anti-inflammatory effect of tetracyclines in that condition. Sun protection is again something that is worthwhile to recommend to rosacea patients because most of these cases can be worsened by sunlight. So sun protection can be beneficial. And also there are other management options, especially for the flushing and erythema, telangiectasia, for example, topical brimonidine tartrate, which is a vasoconstrictive agent. But we do have to be mindful and tell patients that as the vasoconstrictive effect wears off, the flushing can come back again. Laser treatments and other light treatments, for example, intense pulse light, can also be beneficial, especially for the erythema and the telangiectasia, for example, pulsed dye laser. So let me just go back to the chat and have a look again. So that's a good question, Vicky. Thank you. How would you decide which treatment to start first line? Metronidazole okay to use long term? So this is a good question. Thank you, Vicky. So it would depend on the type of rosacea. So for example, for the papulopustular one, it would be topical ivermectin or metronidazole more so. For the erythematotelangiectatic, where you don't see, for example, pustules or papules, but just the flushing and telangiectasia, if you have access to laser, pulse dye laser, for example, in a service, that would be good, or the topical brimonidine tartrate, the vasoconstrictor. Cosmetic camouflage is also an option, which I forgot to mention. So that is also something that can be used, and some patients might say that's all they need, because it might just be that they get some episodes of flushing and they feel self-conscious about that. So that's also worthwhile to explore. So one is the type. The other is whether they've tried something already. So, sometimes we do see patients who have already tried something, for example, and it didn't really help, didn't really work. And then azelaic acid is another option that we can try, which might be beneficial. And the low-dose doxycyclines, again, some patients, so it is important to discuss with the patient individually. Some patients don't like taking antibiotics, especially not longer term. But some patients are happy, especially if we tell them it is low dose, the doxycycline, though. So there's especially in the UK, a 40 milligrams modified release doxycycline, which is in many cases not available. So we might up prescribing the 50 milligrams low dose capsule. And for rosacea, it is definitely a good few months to start off treatment. And the patients are there on it sometimes longer term. It is that patients might want to stop, or if they're in remission, we might consider stopping it. But if they relapse, and again it really causes quality of life impairment, then low dose doxycycline is something that can be continued for longer term. So I would say it really is a discussion with your patient, what they've tried, and the type of rosacea as well they have. And for the phymatous forms, which is a bit more common in older and male patients, it might be some ablative laser treatments to remove that excess, the phymatous material, which can especially affect the nose, for example, or low dose isotretinoin, low-dose retinoids, for example, are also an option. So I hope that helps. And there's one more question with rosacea by Sophie. Lots of LED devices with red, blue, green, various wavelengths. That's right, absolutely. And they're being marketed to target the erythema. Do they have a clinical role in the treatment of rosacea? Well, if you look up the literature, a lot of things have been tried. The most effective ones are the lasers that target, so the vascular lasers, that would be, for example, the pulse dye laser, IPL, intense pulse light, which is not a laser, of course, because it's not a monochromatic wavelength, is also beneficial. LED lights, they've been tried, so they might have a role, but definitely the most effective ones are the vascular lasers in rosacea. Okay, so my next case is a lady in her late 50s who's developed this annular maculopapular rash you can see on the arms, but also on the upper chest. And where you can see the plaster is where a skin biopsy has been performed to help with the diagnosis. And this is a case that belongs to the big family of cutaneous lupus. This is a subtype of subacute cutaneous lupus erythematosus, so SCLE. And we know that the cutaneous lupus family, it's a big family, and it encompasses lots of different types of lupus, but they are ones that are, again, photoaggravated dermatoses. So they're not caused by sunlight, but they are worsened, exacerbated by sunlight and UV exposure. And in the big lupus family, many different types of rashes are there with the chronic lupus, which is the discoid lupus erythematosus, which is typically hypopigmented and can appear with causing scarring as well. So marked inflammation and hypopigmentation can be present, as well as scarring, mainly appearing in sun-exposed sites, for example, the face. Then there's subacute cutaneous lupus erythematosus, which tends to be like this, so annular, papulosquamous, maculopapular rash affecting sun-exposed areas, such as the arms, the upper chest, for example, the upper back as well. And then there are the rashes associated with acute cutaneous lupus, for example, the malar butterfly rash, which is also a part. And I'm not going to go more into details with lupus because it's a huge family, and we could just spend a whole day talking about lupus. But with management, I will say that it is one that usually requires a multidisciplinary approach involving many different specialties. For example, rheumatology alongside dermatology, just to name another specialty, but many other more specialties might be included in the multidisciplinary management of patients with lupus. Now let me go back to the chat again. Urticarial appearance, would it also raise suspicion of solar urticaria? So thank you, Sophie. I appreciate that you don't have the chance to examine the patient, and on the photograph it might look a bit urticarial, but on the history that would definitely be there, that this is a rash that's there that doesn't come and go like hives do. So with solar urticaria, that is a typical urticarial rash where, upon sunlight exposure, within minutes, the patient develops hives and wheals, but then they do settle and they do go. And here with subacute cutaneous lupus erythematosus, this is not one that comes and goes. But it's one that's present definitely for more than 24 hours. So the history would help you with it. And if you feel it, it's not as edematous, so it's not really like hives, it's more thinner or thicker plaques. So it's something that you can feel. And again, I appreciate these are just photos, so it's a relevant question, but you could feel that it's not really urticaria, it's not really hives, but it's more plaques. Sorry, I wanted to go back to the chat. It's not always easy to bring it up. Great. So I hope that helps, and we move on to the next case, where you can see this quite inflamed violaceous erythematous rash with some telangiectasia on the upper chest of this lady who's in her early 60s. And this is a case of dermatomyositis that I've brought you. So staying in the group of collagen vascular disorders, moving on after lupus, I wanted to show a case of dermatomyositis because this is also one that is typically a photoaggravated rash that can be worsened by sunlight. And sun-exposed areas are typically affected with dermatomyositis, for example, the upper chest, as we can see here, but also another typical cutaneous manifestation is the heliotrope rash, where the rash is located on the eyelids, and it's erythematous, violaceous, and can be a bit edematous as well. And another special manifestation in dermatomyositis could be the Gottron's papules, which are, again, similar erythematous violaceous papules or small plaques located on the knuckles, so on the backs of the hands, again, in another sun-exposed location. And similar to lupus, dermatomyositis would also include multidisciplinary team management. Okay, so moving on to my next case. This is a different type of photosensitivity. So this case is a type of porphyria. Moving on. And what you can see here is skin fragility with excoriations. You can see a few milia like cysts on the backs of the hands. And this is a case of variegate porphyria. So this patient has variegate porphyria, which is much rarer than porphyria cutanea tarda. But it presents with similar cutaneous symptoms, such as skin fragility, milia-like cysts on the backs of the hands, and can affect the upper chest, as you can see here. And with variegate porphyria, it's a condition that has an autosomal dominant inheritance pattern. and it can also come with acute attacks. So not just cutaneous symptoms, but it might come with acute attacks, and therefore abdominal symptoms, neurological symptoms might also complicate the clinical picture. The acute attacks are usually brought on in these patients after some sort of trigger, which is usually a medication. Now, the next case is a rare case, and it's an entity that is still a bit debated. It's been described a good few years ago now, but not that long ago. And it's called actinic folliculitis. And the special features are these tiny pinpoint size monomorph pustules. They tend to affect the face. It tends to be appear in a cyclic annular manner, so yearly around spring and summertime. This is something similar to PLE, polymorphic light eruption, where the rash tends to come with the nice good weather spring and summertime. But unlike PLE, this presents with monomorph, small, sterile pustules on the face. And this is a woman in her early 20s who said that this rash had come on every springtime for the past few years and has been diagnosed with actinic folliculitis. Now I have a few more cases to show, and you could see that the previous cases were all related to sunlight or UV exposure in one form or another. Now, we are moving on a bit towards some more environmental challenges and issues. But this one, which is a typical bullseye rash or target lesions, you can see is a case of erythema multiforme, which in some patients may be exacerbated and worsened by sunlight. And we do know that there are many different causes for erythema multiforme, and I'm not going to go into this. We don't have the time for it in this webinar, but we know that infective causes, drugs can also be in the background. So infections such as mycoplasma infection, and this is again another environmental challenge with infections being able to cause a myriad of skin rashes, for example. So erythema multiforme, I wanted to show this nice clinical image of the typical targetoid or bullseye lesion, which is associated with it. Now, the next case I've brought is a case of, I'm just moving the window a bit here, the Zoom window. So this is a case of bullous cellulitis. And again, of course, this is an infection, but I wanted to showcase that whereas cellulitis and erysipelas is usually not associated with blistering and bullae, in some cases it can be. So it is worthwhile to consider obviously the diagnosis if there is blistering. The history would definitely be helpful. You know, the patient might have fever, chills, be generally systemically unwell. When you again examine them, you could feel that this is usually warm upon palpation. You can already appreciate the edema in the pictures, which you would be able to palpate as well. This is another different type of issue, and this is a thermal injury, a burn. So this is a 15-month-old toddler who just started walking a couple of months ago and unfortunately has poured some hot coffee as an accident over his foot. This is a superficial type 2A degree burn, whereas you can appreciate that there was a big blister which is now denuded, but the background is erythematous, and it affects the superficial dermis, and this is one that can heal without scarring, thankfully, because it's a superficial 2A type burn. Now, this is just, again, a case that I wanted to showcase as part of, environmental challenges as the skin. This is simply due to a trauma, due to occlusive footwear, a too small shoe, and basically the shoe being uncomfortable and not good enough for the patient, not fitting well enough. And this may cause a reaction like this on the heel. Diabetic patients or patients with peripheral vascular disease might be more prone, obviously, to developing something like this. Now, this is, again, another special type of rash, and this is a side effect with phototherapy. So this is a psoriasis patient, a young female undergoing narrowband UVB phototherapy, and this is a burn, which is a side effect, and it's the most common side effect with narrowband UVB phototherapy, a sunburn type reaction. And it might happen due to the dose being too quickly increased, the phototherapy dose, or the patient missing a couple of sessions and the dose not being adjusted for that, or, for example, a simple human error of inputting a higher dose in the UVB machine. And topical steroids can be beneficial, obviously. Skipping, then missing a few phototherapy sessions, and in some cases phototherapy might be stopped, but in other cases it might be that it's just stopped for a few sessions and then gradually resumed with a lower dose. My next case I wanted to show you was a chemical burn. So this is, again, a baby, and you can see around the umbilicus this rash, which is due to some sort of topical agent that was used around the umbilicus, and this is a chemical burn due to the irritating potential of some sort of chemical agent, a topical agent. And this is a side effect of another treatment, which is an expected consequence that may happen. This is a cutaneous wart that has been treated with cryotherapy, liquid nitrogen cryotherapy, and a single blister on an erythematous background has developed. And this is a natural consequence that may appear with liquid nitrogen cryotherapy, and is something that we should be advising our patients might happen. And my last case that I wanted to share with you, and then we will conclude the session, is a case of, or two cases of frostbite. And you can see that I brought these images from Visual DX. So this is a source that you can also access through your student intranet. If you type in Ovid, then click on Ovid, you will be able to access Visual DX, and I would recommend for you to look it up because it has really fantastic images and a huge image gallery across multiple different skin tones for different rashes and skin lesions. So I think it's a really good resource to use. And with frostbite, you can see the gangrene and necrosis that may develop, unfortunately, and it may even require amputation in some cases. And this is another environmental challenge that might affect the skin. And these were all of my cases. So I'm going to stop sharing my screen now and do you have any final questions? Because we are going to finish the session and the recording. And thank you for putting your questions in the chat. I hope I was able to answer them, and I hope you found my answers helpful and the session as well. Thank you, Vicky. Thank you, Sophie. Okay, I'm glad you found the session informative. That's great. Then if you have no more questions, have a nice weekend, and we are going to finish the recording and the session. Bye, everyone. Take care.
Sorry, Flora, I appeared to get kicked out about 5 minutes before the end then, so I've had to rejoin. As such, I can't seem to stop the recording. If this is still in, I will edit it out this afternoon.
That's
I don't know
okay.
if you're able to on your end.
Is it still going though?
It is still recording. And when I
Mm.
rejoined, I was a little bit worried that it wasn't going to be, but as soon as I rejoined, it said that we were still
That's at least
recording.
good. Yes, I can stop. Okay, there we go.